Next on Being Well, Orthopedic Surgeon Dr. Chip Rowe is here to talk about joint replacement and what we need to know now to keep our joints healthy. Dr. Rowe will also discuss what type of surgical options are available and what you can expect if you need a joint replaced. That's just ahead on Being Well, so stay tuned. Well, I'm so happy that Dr. Chip Rowe, orthopedic surgeon from Paris Community Hospital, has come back on the show. Last time we had you here, we were talking about arthritis. And this week, you brought some joints with you, as you're going to talk about joint replacement. Just give us a little overview of what causes our joints to wear out.
Well, number one, I'm happy to be back. It's a nice follow-up from what we talked about before. Arthritis, plain and simple, is just the wearing out of our built-in anti-friction device that covers all the surfaces of our bones where they enter into a joint, which we call articular cartilage. Cartilage is one of the few tissues in the body that doesn't have the ability to heal, and so over time it can wear out. Sometimes it's caused by a specific traumatic event, sometimes genetics enter into it, sometimes it's alignment, knock-kneed, bow legs. But when that cartilage wears out, instead of having a nice, smooth, relatively low friction joint, you end up with divots and potholes, which causes friction, which results in inflammation and pain in the joints. Oftentimes there's loss of motion, there's swelling, and unfortunately we don't have a way to go in there and put new cartilage in there. So our option is to put in new, nice, smooth, shiny surfaces that kind of replace the function of the worn out cartilage.
Okay. So how do you as a surgeon determine when a joint needs to be replaced?
Well, I don't actually determine it. I put it in the hands of the patient. One, yes, there has to be evidence that there is arthritis, which is partly taking the history, listening to the patient. They have pain with getting in and out of a chair, going up and down stairs, or walking distances, and typically they're limited in those abilities. And then I look at the x-rays that tell me that yes, we don't have that nice smooth cartilage surface in there anymore. And I tell them, you know, what their options are, and that it's their decision that when they get to the point where day in and day out they can't do the things that they want to be able to do, that's when the potential benefits outweigh the risks of considering surgery.
Okay.
And so it's their decision to make, because everybody has their own anxiety about surgery, and you know, they've talked to other people who either have not had a good result or have had a good result. So it's their decision to make based upon their assessment of their quality of life.
Okay, so we've got several models of joints. Which joints can be replaced in the body? Can you do just about any type?
Well, particularly now with some of the, and I would still call it experimental, although the spine surgeons may say differently, they're now actually replacing some of the worn out discs or the joints in the spine. But probably at one time or another, just about every joint in the body has been replaced with an artificial joint.
What's the most common type of joint replacement?
The most common throughout the world is knee replacements. Interestingly, arthritis in the knee is about 4 or 5 times more common in women than it is in men. So the knee replacement is the most common.
Okay, now you've got a joint with you, or you brought one, that looks like an unreplaced joint. This is the way they
I
look.
brought a model of a hip joint.
Okay.
And the hip joint is the second most commonly replaced joint in the body. And the typical joint would appear very white and shiny and smooth. The analogy I use, it's like an ice skating rink that's just been smoothed out before someone skates. An arthritic joint looks like somebody's just played a hockey tournament on the ice. It's kind of chipped and broken up. And so in the hip joint, we actually have a ball on the end of the thigh bone that integrates into a socket, which is literally just a recess in the pelvic bone. And normally there's a nice round surface in a cup surface, and so you get a nice smooth range of motion. Now, if that were to wear out and the person were having limited range of motion and significant pain, limited ability to do the things they wanted to be able to do, in the hip we would perform a hip replacement surgery. There's kind of gets confusing because they talk about hip resurfacing, they talk about hip replacement. In effect, it all boils down to the same thing. We need to provide new surfaces that move to relieve the pain and restore the range of motion and the strength. So in the hip, there's two things that are done. One, there are special tools that allow us to smooth and polish the inside of the hip socket to particular sizes and fit, and then we would take a component typically that's made out of metal that has some sort of a rough surface to help fit it in place. And so to replace the socket, we would take that shell and we would put it in that prepared socket. And that shell then has some sort of a liner. Typically in the hip we use plastic. So it's a modular component. We have a metal shell which provides the support and the fixation, and then we have some sort of a liner. Commonly it's plastic. Recently there's been issues with using a metal lined shell. There is also the option of a ceramic shell. So that would fit in the cup, and that's how we restore the worn out hip joint socket. With regard to the ball, what we do is literally cut or remove the ball, preserving various amounts of the neck. With a hip resurfacing, you're basically just removing the ball, preserving the neck, and you have a cap that fits over the neck. The typical, more common, is what we call a total hip replacement, where we actually remove a portion of the neck, and then we have an implant that has a neck and what we call a trunnion for the ball and a stem that fits down into the canal of the bone. If we were to look at the inside of the bone, it's actually relatively hollow. That's where the bone marrow is. We actually hollow that out, and we would actually fit the stem down into the canal. It restores the neck, and then we can adjust the leg length and the fit by using different size balls that fit on there. In a younger, more active individual, we would typically use a ball that's made out of ceramic. It has less friction and tends to wear a little bit longer. At least that's what our studies show us. The other option, which is tried and true, is actually to use a metal ball. And so then that all fits in inside of there. And so what we end up with is a new ball in the socket, which restores a nice smooth surface. Our own body provides lubrication, and it is regarded as one of the most successful operations that's performed of any type because of the predictability of the pain relief and the restoration of function.
How long are these joints intended to last in the body? Before, if you needed a hip replacement at 40, are you going to need another one if you're alive and kicking at 80?
The ongoing goal is to try to make them last as long as possible, and that's why in some cases we'll use ceramic as opposed to metal. What we're seeing today, and this is real data, not actuarial projections, is that there's about 1/2 to 1% per year failure. Translating that into understandable terms, that means at 20 years, there's between a 10 to 20% chance that it will have, in effect, worn out. The way they wear out is either the plastic wears out or the component becomes loose, both of which can be a source of pain. And if that's the case, then what we would do is we would go in and remove the implant. If it's just the plastic that's worn out, we can actually just...
I was going to ask, can you just replace certain parts?
We can just replace the plastic. If there is loosening, what we would do is we would take the whole implant out, kind of reshape it, get down to good bone again, and replace it with a new implant. And so those are pretty darn good odds when you consider, you know, if you have the transmission of your car redone, they're only going to guarantee it for probably 6 months to a year at the most.
I have a question. How does that implant stay in there? Is it glued, or does the bone sort of knit itself to that?
We have both options.
Okay.
The old gold standard used to be to use glue. It's actually a variation of super glue. We call it methyl methacrylate. And it actually serves as a grout to hold everything in position. That was one of the shortcomings with the early total hips. They would tend to loosen either at the interface of the bone cement with the bone or with the implant. We've gotten away from that because as we've studied the biology, we've realized that with certain materials like titanium, which are very biocompatible, the bone will actually grow into little pores or actually kind of grow around it, and so you get kind of an interference because of the growth into it. And so more often today, particularly with hip implants, we see those done without any cement at all. In the knees, we more often use cement to hold them in position because of the difference in mechanics.
So who makes a good candidate for a hip replacement?
A good candidate is someone who's going to listen to the doctor. The thing that I tell my patients is you need to treat your joint replacement like your one Rolls Royce in life. And you shouldn't be taking it off-roading. And what I mean by that is, you know, yes, it'll withstand pounding and wear and tear, but that's going to shorten the life of it. So really the ideal candidate is somebody who's probably in their 60s or 70s, who's ideal body weight, who's not a smoker, who doesn't have diabetes, and is not looking to go back to playing tournament singles tennis or competitive soccer or racquetball. The person who wants to ride a bike, swim, walk, that's the ideal candidate.
But it doesn't mean if you have that joint replaced that you have to baby it and, you know, say, well, I don't really want to do anything because I might ruin it. You do need to stay active.
I encourage people that they are made for all the everyday sorts of things that you want to do. You know, spending time with your families, going to the mall shopping. If you want to play some doubles tennis, and I watch you play and you're kind of a finesse player rather than the type that wants to run down every stray ball. Yeah, it's meant to restore your quality of life, and that's a little different for everybody.
Well, you brought a knee. You've kind of explained how the hip replacement works. Talk to us about what goes on when you have a knee replaced, because that is the most common.
With the knee replacement, and I'm going to disassemble, the knee is just the thigh bone perched on top of the shin bone, and it's intended to function as a hinge. And again, what happens, the cartilage can wear out and you end up with pain and swelling and diminished range of motion. And so what we do with the knee replacement is surgically we go in and we prepare the bone to match the shape of the implant. So on the end of the femur, pretty much irregardless of whose implant you use, we end up with a metal cap that fits over the end of the thigh bone to restore the normal shape and configuration of the end of the thigh bone. On the top of the tibia, which is normally flat, we make sure it's flat, and what we're trying to do is restore normal alignment so that the joint is horizontal to the floor. We try to avoid knock-knee or bow leg. And so what we do with the tibia is we start off with a metal surface. In most cases, you can use nothing but plastic. So that serves as a tray. And then again, to make sure that we have what we call the appropriate tension or ligament balance so the knee doesn't feel loose and sloppy, we have different thickness plastic inserts that then pop into the tray, and then we restore the normal position. So then we have the thigh bone moving as it should. We preserve as much as possible the ligaments on either side. Ligaments are ropes that connect bone to bone. And we typically sacrifice either one or both of the ligaments that provide anterior stability or posterior stability. And we can replace that or substitute for that by the shape of the implant. So this little prominence that we see, that would help prevent movement of the knee forwards or backwards, but still allow the nice rotating motion. And knees tend to take a little bit longer to recover than the hips do, just because there's kind of less soft tissue padding. There tends to be a little bit more pain and swelling, but they do equally as well. And there's about 1 million total knee replacements done in this country a year.
Do you typically, if someone needs both knees replaced, do you do one at a time or do you do doubles?
I talk to the patient about that. Part of it depends on their overall health and how much both knees are bothering them. I personally feel that there's no reason not to do both of them at the same time if both of them need to be done.
Okay.
What I tell patients, it doesn't double the pain, it doesn't double the rehabilitation time. They're only subjected to one operation and one recovery, but it's a bigger operation, and if they're already not in very good health, you don't want to overburden them. So it's a judgment call, but I encourage people, if they are in reasonably good health and are going to need to have both of them done, probably within a year's period of time from one or the other, I encourage them to have both of them done.
Well, and I think my mother had her hip replaced and then needed the other one replaced because one gets worn out more because the other one was so bad. Do you find that happens with knee joints, that you fix the one and now the other one starts to suffer because it was taking the burden of the one that was hurting?
Well, to some extent, but I don't know that that's ever really truly been proven. It makes common sense, but the fact that they have arthritis there as well, you usually replace the worst one and that feels better, and then they really appreciate how much the other one bothers them.
And then we need to get them both replaced.
We actually now have the option of doing bilateral hip replacements simultaneously. Some people will do it with the older approach, the posterior approach. I use what's called an anterior approach, where the patient is lying flat on their back when we do their hip replacement, and that actually allows us to replace both hips at the same time if they need to be done. And I've done several of those. Okay.
Well, not that we wouldn't want to come see you as our doctor, but talk a little bit. We got about 2 minutes left. What are some things that we can do now, if you're in your 30s, 40s, to sort of help our joints so that maybe we won't need a replacement later in life?
Probably the single most beneficial thing is consistent, appropriate exercise. And I emphasize consistent, something that you're doing at least 3 or 4 days a week, and appropriate exercise. A joint that's wearing out, if you can unload it a little bit, you're not going to get as much friction and consequently inflammation and pain. So things that can help minimize the load or the weight across the joint. So I'm a big proponent of riding a bike, also getting in a pool, either walking in a pool or swimming or aqua jogging, someone where their arthritis is not real severe, something that promotes range of motion. What we're trying to do is keep that joint surface smooth and lubricated. The other thing is keeping your weight down, and what is often not mentioned is not smoking, because smoking does cause damage to the cartilage surface.
Okay, well, thank you so much for coming on the show and talking to us about joint replacement. I learned a lot today, and hopefully our viewers did too.
Well, thanks for letting me share with you. I hope people learned something and can take advantage of it.
Yeah, well, we'll look forward to having you back again on Being Well.
Thanks, Lori.